grew up in a very small town in northern Oklahoma, population a lot less than 1,000 people. And it was an area where it was sort of an oil field area. I think by most standards it would be considered a poverty area. It was a great life. You know, I loved living there, Shidler, Oklahoma. And we actually occasionally had a physician and occasionally had a dentist. But we always had a pharmacy and a pharmacist. And when I was in junior high, I worked in the pharmacy and doing various things. I painted the building, I dished out ice cream, and I assisted the pharmacist. And it was an amazing experience for me because it gave me an opportunity to interact with people who were coming in and asking the pharmacist a lot of questions, a lot of health-related questions, not just about their medicine, but about their kid's sore thumb, about an ankle. And he was very engaging. And he suggested to me that since I was never going to leave the small town, which was my world at the moment, that maybe I should go to pharmacy school and come back and run the pharmacy for him. And I thought that was a grand idea. And so I did that. I went to pharmacy school, and when I got out of Oklahoma, this small town in Oklahoma, of course I was very nervous because I just felt like it was such a big world. And when I got there, my interest broadened a bit, and I graduated from pharmacy school. And at that point, I got a phone call from somebody who worked for United Mine Workers, and they had a foundation in Appalachia, and they were recruiting nurses and pharmacists and physicians and other healthcare professionals to come to this small area in West Virginia and provide health care to mine workers and their family in this very, very remote. So I went from a very small town in Oklahoma to a very small town in West Virginia. The cultures were both areas of poverty. The cultures were alike and yet somehow different. And when I was there, I had this experience of walking into a place that I thought would be a pharmacy. And what it was really a big storeroom with gallons of theophylline. Now, at that time, the major issue with these miners was black lung and brown lung. And the second cause of death, in my view, was theophylline toxicity, because it's a very dangerous drug with a very narrow therapeutic range. And what I walked into were gallons that they would just be handing over to them. So it was an interesting challenge, and it made me think about, why do people make choices, and how did this happen, that this evolution of just handing somebody a bottle of theophylline, how did that happen? And it was an eye-opener for me, and I thought about coming back and going into an area of pharmacodynamics or pharmacokinetics, and then it occurred to me, I don't think we know enough about how these drugs actually work. So then I got a PhD in pharmacology and neurophysiology, and sort of set me on the road. So my parents did not go to college. They were inquisitive and curious and very supportive. And there were two major ethics that sort of helped shape my being, I think. And my father, believe it or not, was really that the ethics of work has to be work-life balance and integrating your family, which was very unusual at that time, and it's also very unusual for a man at that time. And I realized he never said the words, but he did it. So his office, which was, we had a trucking company. My family owned a trucking company since 1901, and so he was the part of this in this small town, and he always came home for lunch, and every time I had a question about math or a sentence structure or music, I played the piano, and my father was an athlete, and he wanted me to be an athlete, and I adored athletics. Every time I had a question about that, he made time to answer that question. So to me, my father's sense of ethics was integrating family values with a sense of work. And it wasn't, and he didn't talk about it, he just did it. So it was just part of what I grew up with. That has always sort of been in my mind about my father's sense of work-life balance was part of being an ethical person. He was kind of the big Southern, when you look at him, you sort of see this, you have a caricature of the Southern Big Daddy. And in many ways, he represented that, but in all the ways I just shared with you, he really shaped that kind of thinking about integrating your family life with your personal life, and also your personal, with your work life, and also your personal ethics with your ethics at work. So he had a very strong work ethic. Work was 24 hours a day and family was 24 hours a day, and he just seamlessly navigated that. I got my PhD, and like anybody that's getting a PhD, you're sort of steeped in the science and the research, and so I had the opportunity to I did a fellowship at Northwestern, and then but my PhD experience sort of mirrored my growing up experience, because my mentor really believed in integrating research into improving clinical care, and at the same time he had this ethical standard of quality and excellence. And his advice to me was, every time you do an experiment, you have the opportunity to do the best possible experiment that you can do. That's your opportunity. If you don't do it, you have to question your ethics. So it was an amazing, and I have a picture of him in my office, because I always remember that with every experiment you do, you have the opportunity. And if you don't take advantage of the opportunity, you have to question your ethics. So he was a fundamental basic scientist, but he was able to integrate that into, there's an ethical aspect of doing research, whether it's a signaling pathway or looking at a vasoconstrictor agent or thinking about a new gene. There was an ethical part of doing the research and an ethical way of thinking about why you're doing the research, which was, so in some ways I had another, from a different perspective completely, but there were some themes that I think sort of I got to benefit from. So that was my undergraduate experience. And then when I went to my first faculty position was the University of California at Davis, and it was interesting because they were interested in an investigator, and they wanted somebody to fill this gap in their research portfolio. But they also wanted somebody that could span boundaries between clinical medicine and basic science. So I grew up with that in my graduate work with Dr. Brody, so it seemed sort of natural. And then it became not just natural, but a passion. And it became part of my own ethos to say that my accountability as a scientist is to span boundaries into clinical medicine, into medical education. I am part of academic medicine, and to understand the pressures and perspectives of people that live in that space.
You're at UC Davis.
I am.
And you make a very rapid and multifaceted ascent, and we'll talk about that in a moment. But since research, both policy and research ethics, are the foci of this interview, I'd love you to talk a little bit about the research policy and research ethics programs, the general research program you helped build while there.
So I think it might help, the journey might help explain my role there. And of course, if you're a scientist, the coin of the realm is having extramural funding and recognition of your research. And so I was fortunate enough to have that. And then it was an ethical experience for me because I was approached to be the chair of the Senate Research Committee. And in the University of California, the Senate is very powerful. And I was probably relatively junior to have that. And there was some controversy at the institution because there was a sense that there was a bias of this committee to provide intramural funding for basic scientists at the expense of health services research. So there was a sense that of controversy and a sense of unfairness. And I'm coming in, of course, as a basic science faculty and as chair. And so I have to say that at first I think there was some concern and a certain amount of distrust about will she continue this perceived unfairness. So I met with one of the colleagues that was very concerned about this, and they had a suggestion to me, and the suggestion was that we just split the money down the middle. And I said, well, let's think about what that can mean for quality, because we're making an arbitrary decision, not really based on quality, but based on the concern or fears about being left out of the process. So I asked them to trust me for 6 months, included them in all the reviews, changed the review process, made it more open, let everybody see the reviews, and I asked them to give me 6 months to see if they thought that was going to be a fair process. And after the 6 months, everything went swimmingly. I think we reached a new standard. And while that really, I can't say that that influenced research ethics, I do think it created a culture of transparency so that there was trust across the various stakeholders engaged in research. And to me, when you're thinking about ethics and you're thinking about policy, you have to start with a conversation that words are understood by everybody and the perspectives are shared by everybody. So I think that you always start with trust, and that's sort of bidirectional. And then how you think about what does an ethical research program look like. And it doesn't just look like compliance. It's much more than that. But you have to establish the trust. So for me, that was an opportunity for me, whom these other people didn't know, to establish what turned out to be a very trusting relationship. And I have to say that we're close friends to this day. So that beginning, I think, was an important beginning because it really put me in the position of saying, to me, from my own personal ethics, is that spanning boundaries and learning about the perspectives of others is what I'm about. So that was fortunate. I think it helped me throughout my career at Davis.
Another aspect of your career, both at Davis and certainly in general, has been your commitment to the advancement of women
Yes.
in medicine and
Yes.
science. And again, I'd be interested in hearing as much as you're willing to share about both the genesis of that interest, the barriers you encountered, the successes you've achieved.
That was an interest of mine even when I was in graduate school, and I'll just share this one experience that when I was my first year, every student gives a research seminar, and I gave a research seminar, and the faculty evaluate you. And they evaluate you. They orally challenge you or ask you questions, and then they do a written evaluation. And I gave mine, and I had some questions, and I thought I handled the questions. And I looked at the written comments, and the written comment said, "You have a very nice voice." And of course, my question was, I wonder how many of the men got that comment. You have a very nice voice. And that had a significant impact on me. And I, as a result of that, I started chatting with some of the other women graduate students about having a presence at the podium and thinking about how to confront if that shows up in a written evaluation, because that takes up a lot of space that some other words could have taken up. So that was a lesson early on. And I actually talked to my mentor, Dr. Brody, about that. And I'm not going to share, I'm going to modify exactly his device, the way what he said to me, but he said, Anne, every time you run into, I'm going to use this word, not the word that he used, a jerk, just keep in mind it's giving you practice for the next bigger jerk that you're going to meet in your career. And I actually use that to talk to women students that were coming up behind me. And so it kind of became our mantra every time something like that happened. We said, well, it's just giving us good practice for the next iteration of that. And I also think that it was part of my, maybe just part of my DNA to sort of think about that. You know, my father, in a small town, girls start doing competitive sports in the 4th grade. So you do have this sense that you can be part of a team and you can manage conversations, but you can also manage physical activities. And there's a certain sense to me, like it's interesting that you can be a great basketball player in high school in Oklahoma, and the boys are good basketball players, and they go to college and think about sports, and you go to college and there's no more sports for you. And that seemed, I didn't appreciate that was the case so much. So I always had that, and I always felt that this notion that there weren't enough women in the pipeline, I'm not sure who started that notion, but I frankly didn't believe it. And I had a conversation with a colleague of mine, and we were talking about it, and she said, this is the way I think about it. These are her words, not mine, but they stuck with me. She said, I'll give you 3 women assistant professors. You give me 1 woman chair. And at the end of 5 years, I'll have more women on the faculty than you will. And that's when I decided I'm going to become a chair. And then when I became a chair, I magically, in the first recruitment, I think I had 6 slots, and magically 4 of the slots were women. And it's shocking to me, and all of them, I should say, are very successful now. So it was shocking that the pipeline sort of opened up once there was a women chair. And that became part of the way that I viewed what I do and how I think, that making a case to be sure that there's a case that women are part of the pool. And once they're part of the pool, they can do very well. So that was huge for me. Before I became chair of the department, I had another interesting experience, though, in cardiology. Although I was a PhD, I had a joint appointment in pharmacology and cardiology, and the chair of medicine said, and I want you to become the division chief for cardiology. And at the time, of course, it was shocking because I was not an MD. There were 2 women in the division. And obviously, there were some leadership challenges, and he needed somebody to do that, and so I was able to do that. And when I was in that position, I was able to recruit 2 women into cardiology. Both of them were MDs, and both of them had fabulous research careers. So I got to be, in some ways, in the right place at the right time where I actually could recruit women, and I was very proud of that and felt very privileged because I was in a position to be able to do that.
One thing that many women experience, particularly in medicine and science, is that they had to become more like men in order to survive in a man's world. They had to, if anything, become less nurturing and less willing to use all of their both emotions and values.
Yeah.
And I wonder if you experienced that. If so, how you handled it, both as a chair, as a mentor, and certainly as a professional in general.
So I think the expectations, certainly the expectations are different for women chairs. There is this sense that at least in my view, that there's sometimes a narrow range of acceptable behaviors for women chairs that are a little bit more narrow than some men chairs. And I realize that this could be a generalization, but in talking to other women chairs, expressing emotion has been viewed differently. And I actually made it, I tried to be very careful on how I expressed my emotion and what I was passionate about, especially when I was a chair because of that. Now, whether or not I needed to do that is a good question. I have to say, in my own experience, I have been fortunate, and the women with whom I've had the privilege to interact have all been very nurturing. Many of them are very competitive, but I would stand them up as fabulous role models for any women. So it may be that the trend is going in another direction. Certainly, some of the women now entering medicine and science have a different perspective, and they, I think for the most part, feel like that women that have gone before them have made their lives better. At least that's what I'm hearing from them. And just as I think the women that went before me made my life better. So I think if we can continue to make lives better for those coming behind us, we will have been doing a good thing, both for science and for women and for all of us.
You spoke earlier about your commitment to the other, and clearly your commitment to helping women advance in the scientific world is one manifestation of that, as is your commitment to diversity in
Yes.
general.
Yes.
And I know that you serve on the NIH Working Group on Diversity,
Yes.
and you've served on many other
Yes.
committees and bodies.
Yes.
And I'd like you to speak a bit about where the field was, i.e. diversity, in medicine and science when you began, and where you think the needle's moved since your involvement.
Certainly, the environment for women, and the data bear this out. I think we have certainly increasing representation of women in science as well as in medicine. Other underrepresented groups, sadly, we have not made that progress, and certainly that's unfortunate. Let me just put this in a broader context. And to me, every person should be empowered to claim their own wellness and dignity, and through being part of the care system, through being and participating in research. So I feel like we have to have a different language for how we think about those underrepresented or disenfranchised or underengaged. And from a research perspective, if I may for just a moment, I feel like that our language suggests that we're doing experiments on them, on somebody. And my view is that we should be engaging all of our citizens to be part of a giant research community where they say, these are the health needs. How can you help us meet our health needs through the full spectrum of research? Through what can I do to change my behavior, and what is the evidence for that? What are you thinking about new treatments for my child's cancer? What are you thinking about new treatments for sickle cell? I mean, this is affecting my children. And so in embracing all of us as part of this together, rather than we are the researchers, they are the subjects, they are the patients, they are. And I think it's time that we think about who are we, and we should be part of this community. So this is for whatever reason, as I get older, this becomes more and more prominent. And when I see a person on the street, and I think, what's important to them about their health? And I'm pretty sure that they don't care about a medicine promotion system. I'm pretty sure they don't care about who's first author. I'm pretty sure they care about what are we doing to make their lives, to empower them to have some ownership in their own health and understand that they are part of we. We are we. So I'm sorry to get off a little bit beyond the diversity of the workforce, but I find that it's becoming more and more important to me. And in fact, I have this sort of mantra in my head that everybody deserves to have a sense of dignity and wellness and resilience that comes about through access to health care, through access to research, and being part of we.
Would you speak a bit about what you see as the barriers to minority advancement, both in numbers and professional heights?
Yeah, that is such a tough question, and certainly people have spent a lot of their career thinking about it. I sort of come back to this fundamental sense of belonging and feeling that you can do it. And part of that may have come from my own being part of a small town. This was not a high-ranking school system. And sort of thinking, I don't think I can make it in that career. I mean, I don't think I can make it because, I didn't have chemistry or physics. I didn't have that in high school. And your feeling is, wow, geez, I don't know if I can do it. And then imagine that and amplify that when you're in an environment where not only are you questioning whether you can do it, but there are many aspects of society that's telling you that you can't do it. So that is a very tough hill to climb. So it's creating the environment, creating the infrastructure, and then creating that sort of ongoing support. And I don't think as a nation we've come together with a national strategy to recognize that we have to start early and help those folks see that they can do it. And what I do is I look at some of my colleagues from underrepresented groups who are successful and say, how did you do it? And somebody in their lives, their grandmother, their mother, some faculty person, some other mentor, focused on them and help them with that extra push. And somehow we have to do that for more of them because they deserve a little bit of an extra push because they're coming from an environment that they have to sort of, have other people tell them that they can do it. So I don't have a good answer, but I know that what we're doing is not enough. So notwithstanding the resource-constrained environment, I think an opportunity for the research community is to, when we talk about research, there's that that autonomy and that discovery that can lead to something truly important. And one example would be, probably close to 2.5 decades ago, when Elizabeth Blackburn and other colleagues were working on pond scum. And you can imagine the derision of what are we going to learn from pond scum. And here now we have new understanding of how cells work. We have new therapeutic strategies for cancer. We have a fundamental understanding of that protective cap on chromosome, the telomeres. And so that's an important breakthrough that was started from just being interested in looking at processes in pond scum. So I think we have to attend to that. On the other hand, we have some major healthcare challenges that deserve research to be focused on them in a changing demographic. So when we think about Alzheimer's disease, with a changing demographic, and in 2013, I think there were 5 million people diagnosed with Alzheimer's. The cost of that is in the billions, not to mention the burdens on families and the social cost. And yet, we don't have a national strategy to bring together all of our research forces to think about Alzheimer's. We have childhood obesity, and while we're making some small gains in childhood obesity, the molecular understanding of what's going on, the interaction with genes and environment and foods and nutrients, we have to get our arms around that. I mean, it's much more complicated than kids are just eating too much. And by simplifying that, we lose the ability to actually make a dent in solving those problems. And those are major health issues that deserve the research community to put all of our forces behind that. And I think that's a challenge within our community that we should come to grips with. I mean, childhood obesity, of course, cardiovascular disease, emerging infections. We live in a global environment now, Alzheimer's disease. Those are not going away, and they're going to affect more and more of our citizens. And if we have to come at this together and think about that from a research perspective. So I think that's a big challenge.
The AAMC, and certainly you and Dr. Kirsch leading the charge, have been very committed to addressing real and perceived conflicts of interest,
Yes.
as was Dr. Cohen
Yep.
before you.
Yes, absolutely.
And you've spoken widely about the concept of principled partnerships, and it seems like your concept and certainly your banging this important drum has begun to gain traction. So I'd like you to share some of your impressions about the current state of conflicts of interest, in particular with respect to research.
So so that's part of our ethical responsibility to think about conflicts of interest, not just financial, but other kinds of conflicts of interest, and that always has to be at the forefront of our thinking. On the other hand, I think we have to think about opportunities for convergence of interest, not just conflicts of interest. And when I think about the question, we think about the question: when is it not ethical to partner for research? And I think we also have to ask the other question: when is it unethical not to partner to advance research? So I think keeping both of those in mind and in balance. And I think what we haven't done is ask ourselves, when would it be unethical not to partner to do research? When would that be? And I think that's a question that we have to think about. So when we think about financial conflicts of interest, it's not merely checking the box. It's understanding what can happen with a financial conflict of interest, but it's also thinking about what are ways that we can move this research forward if there is a significant financial interest so that it's not a conflict. And that may be a different kind of conversation that we have to have. Now, there's no way that we can abandon the public trust, but defining the public trust and how they're viewing the kind of research that we do, I think engaging, Primer's certainly done this, I think, is just as well as anybody, is engaging multiple perspectives to say, what is the financial conflict of interest? I think, you know, when we talk about policies coming down about financial conflict of interest and the federal guidelines, I think helping shape those guidelines. I also think, and this is one of the things that we're doing at the AMC, is really collecting evidence from, I think we have over 75 institutions now as part of this, to saying, I'll just give you one example, do the new financial conflict of interest regulations coming down from HHS, are they accomplishing the goals of maintaining the public trust, ensuring human research protections? Are we accomplishing those goals? So we're actually engaged in this metrics project to look at the effect and the effectiveness of that rule. And at the end, what we're hoping to do for NIH and for academic medicine in general is to sort of frame our understanding that for policies around financial conflict of interest, it's not just compliance. Is it an evidence-based policy? And let's go beyond checking the box and examine our own ethics about why and how we're doing research. So we're trying to think about that from, let's shift to an evidence-based thinking about financial conflict of interest, and let's also at the same time elevate the discussion that finances is one part of it, but there are a lot of other parts of it. So it's not asking, this is not ethical, so let's not engage in the research. Let's ask ourselves how to put that in the context, and also ask ourselves when would it be unethical for us not to engage in partnerships to do the research. And to me, that's the crux of a principal partnerships, thinking about the ethics of not doing it and the ethics of doing it.
Thank you for that work as well. You've also been a leader in the national discussion about the move towards a PCORI,
Yes.
and certainly CER,
Right.
competitiveness effective research. And I'd like, again, to hear about the genesis of your interest in both areas, and
Yeah.
then your sense of the state of
Yeah.
each.
So this has been a very interesting journey for me in some ways, because I do come from basic scientist, sort of a fundamental discovery background, but and maybe this is from my whole experience, but I fundamentally believe that it takes the full spectrum of medical research to bend the needle or to improve health. So it absolutely takes fundamental discovery. It absolutely takes clinical research. It absolutely takes community-based participatory research. It takes prevention research. It takes health system research. It takes implementation research. It takes all of that. And if we think in terms of, well, if my research is important and the other research is unimportant, we've just robbed our community of that. So I have this view that if we are going to advance health in obesity and diabetes and cardiovascular disease, it's our ethical responsibility to embrace, value, view, and empower the full scope of medical research. And part of that includes comparative effectiveness research, patient-centered outcomes research. And so I've been a big proponent of PCORI because that kind of research has been underfunded. And we've also, some of our medical schools have told us that they don't have the capacity, infrastructure to do that. So why not help them build that infrastructure? And I also have this bias about patient-centered care, that the definition of true patient-centered care is that the patient and the patient's family care about it and are involved in the decision making, that the care provider has the best clinical judgment. But what's missing from that? The best possible evidence for what works best for whom and why. And if we don't focus on the full scope of research, we lose that third component. So to me, patient-centered, population-centered research takes into account the best possible evidence. And you get that through comparative effectiveness research. You also get that through a fundamental understanding of the pathophysiological basis of disease. So that's my thinking about the full scope of research. And that's why I'm fully supportive of PCORI as well as NIH and IARC and all the other agencies.
What were some of the goals you set when you first came to AAMC from UC Davis? And if you would, talk about some of the barriers.
Right. So I came to the AAMC to ignite a national conversation that talked about the full scope of medical research. And I think that AMC, under David's leadership and certainly Jordy's and also with Daryl's, set a great standard for thinking about financial conflicts of interest. And I also think they had a great standard for being a trusted resource for making the case for biomedical research through NIH. I think what I wanted to do with AMC is to broaden that message to say that the full scope of research is what's going to be needed to advance the health. And so that was actually an internal conversation for the first year because it wasn't part of AMC's, they weren't against it, but I think it wasn't at the forefront of how they thought about it. And that was, so that was one important goal. And so my strategy, I guess, was to have an internal conversation. And I'll just tell you, we had this phrase that if Daryl forgets his slides, he will always think about the full spectrum of medical research, and that's how we will know that we were successful in the first year. And Sandy Kurtz, who's actually running the camera now, is responsible for making that full scope thing. And I have to say now that Daryl says it with and without his slides. The second goal, so the barrier, not that it was an insurmountable barrier, but it was sort of changing the conversation. PCORI wasn't happening yet, but I think there wasn't that kind of, comparative effectiveness research, the IOM report was out, but I think the AMC wasn't thinking exactly along those lines, and that's, I sort of told them that up front, though, so I think they knew that that was part of it. And then the second goal was that I really felt like we needed really a stronger position on thinking about health equity and the dignity of all. And when we're thinking about the health of all. And so that was the sort of a second major goal, and I've been very fortunate that I've been able to bring in senior directors with a portfolio around health equity research and another portfolio around patient-centered outcomes research, and they've been extraordinarily helpful. And then the third goal was to talk about principal partnerships, and not just talk about it, but to say, what does that actually mean? And that's sort of when I started talking about asking ourselves, when is it unethical not to partner? And when I say partner, it's not just with industry. It may be partnering with the county health department. It may be partnering with a school. It may be partnering with a community advisory group, but not partnering around research. That's when I say, let's ask ourselves the question, when is it unethical not to partner? So my definition of principal partnerships was beyond probably the initial scope of partnering with industry or pharma or devices, but partnering with a lot of different stakeholders.
Peter Pan, you read it? Back in Oklahoma, Peter Pan said that sometimes you've got to crow. And so I'd like you to talk for a moment about your proudest achievements, both at UC Davis and here at AAMC, or one or the other as you like it.
I think my proudest achievement at UC Davis was that I think I was actually able to model for others spanning boundaries beyond your own perspective and hearing the perspectives of others. And by that I mean learning from colleagues that come from a passion for clinical care and what's important to them and the pressures on them, and learning from colleagues that come from the passion for medical education that may not have an interest or an appreciation or understanding of research, but learning from them and sort of being able to go to where they are in their perspectives. And I'm very proud of that, and I think that it has served me well. The proudest, biggest accomplishment may have been, I've been asked this question before, was that I was fortunate enough to be the point person to get a $100 million competitive grant from the Gordon and Betty Moore Foundation to start a school of nursing at the University of California. And that was sort of spanning boundaries again, because I, of course, was not a nurse, but because I was the executive associate dean and was able to do that, and I actually asked to be the point person on that. And that was an amazing experience for me, and I gained a huge understanding of what nursing science, nursing research. So I'm proud of that because UC Davis got a school of nursing. But I'm also proud of that because I felt like, again, I was able to span boundaries and learn from nurses about how they think about health and how they think about research differently. So I think it really enriched me, and I was very happy that UC Davis was able to have a school of nursing, because I think it enriches that community also. And the AMC, I have to say that this may seem small, but I'm very proud that at AMC now, I think we view and value the full scope of medical research and thinking how it can improve health, not just of a few, but of the many. And I think the fact that Daryl talks about that and that my colleagues talk about that, I'm very proud. I'm very proud of that. I do have sort of a big goal, and that is that we move from a national conversation about improving the health of all by empowering them to be part of this part of the research community, as opposed to having research done upon them. And so I have this hope that in the next decade, when we think about all people who feel like they're part of the research community, that it won't be 1% or 2%, it will be like 70%. And they will feel empowered to do that and be talking about it in their homes, talking about it to their neighbors, talking about it to their children, so that it will be we won't even think about it. We'll just be defining the research community as all of us being participating in ways that we can make the biggest contribution. So that's my long one. My probably the nearer term goal is to sort of enhancing our voice, to think about, to use the words of the dignity. So not just improving the health, but empowering people to enjoy the dignity that they deserve by being part of a healthcare system where they have access and where they have coverage, but they also feel part of it and not estranged from it or being scared to be part of it. So, and that's an interesting, coming from a research environment, but my thinking is I'm spanning boundaries. I should be thinking about that because there are people around me that maybe don't know that October is a month where they can sign up for coverage that haven't been covered. And so that's a goal. I want us to have a larger footprint in thinking about population health and health equity research, and I think certainly we're getting there. But I want us to do it in ways that we can see a difference at the institutions, so that institutions are feeling proud about what they're doing in their local environment for that. So I would say those are my three goals.
Dr. Bonham, it has been an extraordinary privilege to listen to you, to learn from you. Again, we've scratched the surface, and I want to thank you so much for your time today and for being part of Perverse.
Well, you have asked fabulous questions, and I have to say that it's been a privilege for me and a pleasure talking to you. I hope so. Thank you. Thank you.